Thank you everyone for tuning in, and I see the count is ticking up, so I'm sure we'll be collecting more in the next couple of minutes. Um, for those I haven't met yet, I'm David Rank. I'm one of the inpatient chief medical residents at the University of Washington Montlake, and very excited for our talk today. If I could just remind everyone to please put your questions in the chat or Q&A feature throughout the talk, and then we'll circle back to those at the end. And now I'll turn it over to Dr. Chander, who will be introducing our speaker today.
Thank you so much, David. For those of you who don't know me, I'm Geetanjali Chander. I'm the division head of general internal medicine. And it's really my pleasure today, on behalf of the Division of General Internal Medicine and the Council for Diversity, Equity, Inclusion, and Belonging for the Department of Medicine, to introduce Dr. Kimberly Manning. She is a general internist and hospitalist in the Department of Medicine at Emory University. She's a professor and the vice chair of RYSE Initiatives and the immediate past program director of the Emory University Transitional Year Residency Program. Her clinical work is at Grady Memorial Hospital, Atlanta's safety net facility, where she's been working for over 2 decades. She is known for her innovative and mission-driven approach to medical education and has been recognized nationally for her mentorship and teaching, as well as her blogging and public speaking. She has received numerous awards, including the ACGME Parker J. Palmer Courage to Teach Award. She received a Lifetime Achievement Award by the Association of Black Women Physicians, and in 2022, the AAMC Group on Diversity and Inclusion Exemplary Leadership Award. She's received the highest teaching awards at Emory, at Grady Hospital, and through the residency program. And the City of Atlanta honored her with the 2024 Spirit of Atlanta Award for her exemplary service to patients and learners. Her work has been published extensively in JAMA, Annals of Internal Medicine, Academic Medicine, and Lancet. She has a strong passion for storytelling, which looking forward to hearing more stories today, as a means to build and strengthen diverse and humanistic clinical environments, as well as cultivating psychologically safe learning climates. She is a prolific writer, and is also the co-host of a podcast called The Human Doctor, which for those of you who've not tuned in, I highly recommend it. It is without further ado that we welcome Dr. Manning for Department of Medicine Grand Rounds today. Thank you.
Thank you so much, Dr. Chander, and I am so happy to physically be here. I'm physically in Seattle. I am joining you via Zoom, but I've had such a warm and wonderful time being received by the Department of Medicine and my colleagues here. So it's really a privilege to join you today, and I appreciate your attention. This discussion today is something that I've been thinking about a lot, and something that I think about a lot. And it is really about wisdom at the bedside, all the things that we learn from our patients, who are our most esteemed teachers. Furthermore, I think in a time such as the times that we are in right now, this really could be called wisdom and restoration at the bedside, because the very best of medicine and what restores us is not found in the electronic medical record. It is actually found with our patients. And I hope that we can together take a journey that gets you reflecting more about what we can do to restore ourselves, to sort of stay in it, and to have some optimism moving forward. I do not have any financial disclosures. I am a board member for the ACGME Board of Directors and the Arnold Gold Foundation. But yeah, y'all don't have enough clout yet to have any real financial disclosures. I'll let you know if that changes. Also, I've told some of my colleagues last night who I joined that I cry every single day, 365 days per year. And I do believe that we need to normalize emotion in our work. And I would say especially now, because many of you probably have your moments where you are trying to process your moral injury and your hurt feelings, or just process joy that you feel from caring for patients or working with learners. And I think that's okay. I start every talk that I give from a place of gratitude. First on the bottom, I've been thinking about this sort of web of influence that all of us have. And I think about how when I was a resident physician, how few people I knew who could sponsor me or help me to move forward. And now I think about the power of what happens when we are really intentional about building connections. This picture on the top right are a picture of some and not all of the Black women in the Department of Medicine at Emory who have achieved the rank of full professor. Black women make up less than 1% of all full professors in US medical schools. And the connection and support that I have found in my colleagues, but also, you know, my fellow full professor senior faculty members has been important, but also has helped me to build a web that allows individuals like these two interns who, like me, are HBCU educated to be able to propel. So I'm really grateful for mentorship. I'm grateful for sponsorship, representation, but also connection. And part of the reason why I'm so glad I physically got to come to Seattle. But I'm also grateful for the influence of people who have done work, who create spaces for us to do things that are a little more non-traditional. This paper by Jordan Cohen, who is one of my academic heroes, really has me thinking a lot about the impact, the importance of impact on the work we do, reach and inspiration. This paper, Linking Professionalism to Humanism, What It Means and Why It Matters, was a paper that I read when I was an assistant professor. And the first time I ever gave grand rounds at Emory, it was specifically on this topic, built completely off of the work of Dr. Cohen. But it's really shaped a lot of my career just because I read his paper. This image here was an opportunity where I got to meet him for the first time. And don't think that your work is insignificant. Even people who don't know you may find inspiration in your work enough to move them forward in their careers. So I'm grateful for that. So y'all, despite my youthful glow, in 1992, I was a first-year medical student, and a lot has changed since 1992 when I was in medical school. First of all, if you think about where technology was, there is no way that anybody would be talking to you for grand rounds over Zoom. This is an actual picture from when my family was dropping me off at Meharry Medical College in 1992 for my first day of medical school. And again, so much has changed. There was no laptops. I still remember the person in my class who had a laptop and how exotic it seemed. We had no Wi-Fi hotspots. There was no internet in 92 when I started medical school. And I really still don't know how we knew what was going on the campus because we did not have any email addresses. We didn't have any social media. Pretty much if you needed to do something or you needed to know something, you physically came to school, sat in class, and that was sort of the culture then. That thing in my hand that you see, that is a book. That's because there wasn't, any, podcast to listen to. There was no open evidence. There was no, Copilot, ChatGPT, no quick PubMed search at the tip of your fingers or electronic libraries. Most things, we just had to look at in hard copies. And that was just 2 years into me being in medical school. But as time went on, things began to change. In 1996, the year I graduated medical school, the internet was really beginning to take off. And as I started my internship, I remember getting my very first email address, but also getting my first cell phone, which was approximately $150 per second to use. So we all just rode around with rolls of quarters in the consoles of our cars. There are people I'm sure on the call that are old enough to remember that time where you knew where all the payphones were. And that's what we did. We just went around with, rolls of quarters, and that was how it was. And, a lot was different. I mean, but if you talk to anybody and you think about, okay, there's no internet then. There was no, no Zoom meetings or anything like that then. But if you start asking people what are the most important moments, the most important, most significant teachable moment that you have had or lesson that you have had in medical school or in your career, there's really nothing new under the sun. And I would like to draw your attention here to this picture of this medical student. You may recognize Dr. Anand Bakshi. This is when he was a first-year medical student at Emory, doing one of his first patient interviews. He's now an interventional endoscopist. But those rich teachable moments, they happen with our patients. They're not at the electronic medical record. They're not technology based. They're with the patients that we care for. And so as we, in this time, these very difficult times, as we look for places to find restoration, to find our resilience, but really to find our why and our true north, we really should turn to our patients, the wisdom of our patients, and that can be found at the bedside. And my hope in this talk is that we'll be able to go on a journey together that gets you all reflecting about the immense privilege we have to be with our patients, learn from them, and to keep going. So there's a Native American proverb I love that says, "Tell me the facts and I'll learn. Tell me the truth and I'll believe. But tell me a story and I will keep it in my heart forever." And stories often inform our research questions. They inform what we teach, the curricula we build. But stories often make us stay and feel a reason to keep going. And again, in a time such as this, I thought to speak to you on this topic because now more than ever is a time that we need to be thinking about the why that we're here and why the work we do is so important. I've changed some names and details to protect anonymity, but the images I've shared have been with permission where applicable. So this is a picture of Metro Health Medical Center, one of the Case Western teaching hospitals, the Safety Net Hospital in Cleveland, Ohio. And this is the first hospital where I worked when I started my internship. And one of the very, very first lessons that I got as an intern came from my senior resident who had already matched into critical care. And she looked at me and my co-intern and said, "The only thing you need to learn this month and that you need to learn this year is who's sick and who is sick." Now, what exactly that meant, she couldn't quite explain to us. She said, "You just follow me, you pay attention, and you will find out who's sick and who is sick." She actually looked a lot like the lady from The Incredibles. But whenever I hear that or think about a sick patient in the hospital, I always think of her. And so we were very anxiously trying to figure out who was sick and who was sick every day. And so one of the very first patients I cared for was a man who I'll call Mr. Farrell. And Mr. Farrell was a gentleman who had been admitted to the hospital for a non-healing ulcer on his foot that appeared to be gangrenous. He also had severe advanced COPD, was oxygen dependent, and had come in with a COPD exacerbation along with this wound on his foot. And, this was in the 90s. So that kept him in the hospital for some time as we tried to sort out what to do next. So every day I would come in and see him since he wasn't sick, y'all. He was just kind of chronically sick. He would be up and awake and chatting with me all about his family, but especially his Jack Russell Terrier named Jojo. He would talk about Jojo nonstop. And again, this man was very animated. He was not that sick. And so he would just talk and talk and talk about his dog, Jojo. And for me, a very, very nervous intern who was trying to figure out, how to not do any harm to anyone, I really looked forward to my time with him every day. I would come in really early in the mornings, walk in, and the first person I would see would be Mr. Farrell, who would probably talk to me for 30 minutes straight about his dog. And that was sort of my day. It started to become kind of like Groundhog Day. I'd walk in, see him, hear about Jojo, and go on about my business. So about a week into caring for Mr. Farrell, I come in very early in the morning. This is pre-duty hours reform. So, you could come in as early as you wanted, and the parking lot kind of looked like this. And as I came in to see Mr. Farrell, that particular day, he was not awake and animated and talking, and said he was asleep. And so I came over to him and I tried to shake him awake, and he was kind of difficult to arouse. I gave him a sternal rub and he kind of batted his lashes a little and began to wake up. And once he did wake up and looked at me, I got him to mumble a few words in my direction. But for the most part, he was very, very different than he had been before. So I do an exam, even though he's kind of sleepy, but difficult to arouse. I look at his vital signs. He doesn't have a fever. He isn't tachypnic. He doesn't seem to meet any SIRS criteria, even though we weren't saying SIRS criteria back then. So I thought, it's early in the morning. Even though normally he's awake at this time, it's no big deal. I go on and finish rounding. And shortly thereafter, my senior resident comes in and begins to ask us how things were going. And I said, everything was fine. The only person that was a little bit different today was Mr. Farrell. I went and saw him, and like I couldn't really get him to wake up that well. And then also his oxygen was a little low, and I turned it up. I didn't realize I wasn't supposed to do that. And so this was exactly the look on my senior resident's face. She spun on her heel and rapidly began walking to Mr. Farrell's room, with us interns trailing behind. Shortly after that, Mr. Farrell, a cold blue was called, and by 12 noon, Mr. Farrell was on full pressors, intubated in the ICU. Mr. Farrell was sick, and I had missed it because I didn't have enough experience yet. My senior said to me, listen, some things in medicine don't make sense, but most things do. And at this point, she began to fill some gaps in my medical knowledge. He didn't have a fever, but he was hypothermic. His temperature was 35.5. His respiratory rate was clocked at 22. And I don't know about your hospital, but back then, if somebody's respiratory rate wasn't clocked at 20, that means somebody actually counted. and I think maybe there was something going on with his respiratory status, but especially he wasn't awake and talking about JoJo. Something about him had changed. Mr. Farrell was sick. And I never forgot that. I never forgot that little difference, or that little suspicion that something wasn't right. So time went on, and as time went on in my time in Cleveland, I began to recognize that time that I really spent with Mr. Farrell, sitting in the room with him, hearing about his dog, it really built a rapport and it built a therapeutic alliance, but it also filled my cup in a very difficult time when I was working 120 hours per week. And I had a senior resident following that first senior resident who often told us interns that the other good thing, you should always remember that it's always a good time to go be with the patient. When you aren't sure what to do, or if you're feeling really tired, scared, or just in over your head, go and sit with a patient. You'll learn something. It's always the right thing to do. And so he said some of the best teaching just happens when you're just physically present with the patient. And I remembered that. I saw that as something that I could do. And after a while, I started to mimic the things this senior resident was doing. He would often say, I'm just glad to be here. And I still find myself saying that to teams now. I'm just glad to be here. And so I would often see medical students sitting in a corner, reading, pocket medicine in a dusty corner, or, somewhere just standing to the side. And I would remember what that senior resident taught me. Come on, let's go be with a patient, because going to be with a patient is always the right idea. And that began to stick with me, and began to be a place where I started to build up some courage, and also to know the difference between who was sick and who was sick. So in my intern year, time goes by, and now I got a little more swag, y'all. I can hold a cup of coffee and jump on my classmates' back. And I admitted a patient that spring, who I'll call Mrs. Elmore. And Mrs. Elmore was a woman who had been admitted overnight for community-acquired pneumonia. As the story goes, Mrs. Elmore was at home in her house, and suddenly she developed hyperacute shaking chills and a productive cough. She felt feverish, and she felt extremely bad and a little short of breath. She came to the hospital, where she was found to have a lobar infiltrate on her X-ray. And that lobar infiltrate on her X-ray, along with her clinical presentation, gave her a diagnosis of community-acquired pneumonia. She was given antibiotics and some fluids, And by the time I came in to admit Mrs. Elmore, she was actually doing much better. In fact, so much better that she was not sick at all, even though initially her high fever and story, it sounded like, that she'd be sicker. She was so well that she was cracking jokes. She was asking me if I was old enough to be a doctor, but especially it allowed me to slow down, get to know her and ask her some questions about the history that maybe if she was sick, I couldn't ask, such as, Miss Elmore, what were you doing when all of this started? And Miss Elmore looked at me and said, now listen, baby, I was standing in my kitchen and I was making a banana pudding. And then all of a sudden, out of nowhere, I started shaking a whole bunch. I started coughing and I started bringing up something and it looked like rusty colored. And I just felt terrible. And I knew I needed to come to the hospital. Now, she's looking so well that I start asking her questions about the banana pudding. Like, hey, were you making the real banana pudding with a double boiler? Or were you making the no-bake kind like I make? And of course, she was appalled and offended by that whole discussion. She was making real banana pudding and commenced to tell me all about how to make a proper banana pudding. But most importantly, she was not sick. So I go as a dutiful intern to look at the images, and I discovered that she had a bit of an effusion. Back then, we weren't doing POCUS, y'all. So I did a lateral decubitus film and saw that she had a pleural effusion that actually layered out. And I said, oh, well, that means I need to get a sample of this fluid. I go back to her because I built a rapport with her over discussions of banana pudding and told her that I needed to do this procedure to get a little fluid. And she said, do what you need to do, doctor. But at that time, I felt pretty confident that this would not be an empyema. This would not be anything really worrisome because this patient was not sick. She was up cracking jokes, talking about banana pudding. She was playing solitaire on the bed, cracking jokes with the nurses. So, I was doing my due diligence. I did the diagnostic thoracentesis through percussion, y'all. That was pre-POCUS. And went from there, and it was fine. All was fine. A small amount. I went from there. So I go on about my business, continuing to admit my patients, and things begin to settle down. And then my pager goes off. And when I get this page that says, we're calling you about a critical lab. It's a pH of 6.88 on this bodily fluid. Now, a pH of 6.88 on bodily fluid, the only bodily fluid that I had collected that day was the fluid from Miss Elmore's chest. And the thing about her, now 6.88 in some pleural fluid, that would automatically make you sick. That means you need a chest tube ASAP. And all I could think about was the fact that she looked so well. This person is not sick. This lady is cracking jokes about how young I am. She's cracking jokes about me making no-bake banana pudding. This is not somebody that I want to call surgery about to put a chest tube thoracoscopy in. And some things in medicine don't make sense, as my senior taught me, but most things do. And this right here, it did not make sense. So because I didn't have internet, y'all, I went to the library to see what Dr. Light and his colleagues had to say about this. So I go to look up in the pleural diseases book to see if there is some clause somewhere that says, yes, everybody with a pH of 6.88 in their pleural fluid should have a chest thoracostomy, except for a really nice lady who cracks jokes and who makes banana pudding. Like her, she don't need a chest tube. Everybody else needs a chest tube. Unfortunately, there was no chapter Dr. Light and his colleagues had on that. So everything pointed to her having a clear indication for a chest tube. But I couldn't stop hearing my senior resident telling me that day with Mr. Farrell, does this make sense? Some things in medicine don't make sense, but most things do. And this just did not make sense. And I was an intern, so I knew I had supervised instruction. I said, you know what? Let me go talk to my senior resident to see what he thinks. So I go back and I recount to him, listen, the temperature is improving, the white blood cell count is coming down, and this lady is well enough to talk about banana pudding. And putting a chest tube in her, which is invasive and could make her stay in the hospital longer, is a big deal, don't you think? Well, y'all, that year, my senior resident, I have to say, he was indecisive about everything that month except the moment when I said we should call our attending. He was suddenly very decisive. so decisive that he was like, no, we're not going to be calling the attending. I could not shake this thought that this lady, this was the person we were about to stick a chest tube in. And he said, I tell you what, you call our attending at 3 a.m. and tell our attending at 3 a.m. that somebody who has a pH of 6.88 and some pleural fluid, maybe we should put a chest tube in. You know, you're on your own. And so, again, I couldn't stop thinking about it not making sense. And I began to think about, well, what would it hurt? My attending did say, call if you have a question. Well, I should mention you all, again, this is before everybody has cell phones. So I had to call my attending at his house. And I should probably mention that my attending that month was the chair of the department. Yeah, I should probably mention that he was the chair of the department. I should probably mention that when I called, his wife answered the phone and I heard her shake him awake in the bed. Yeah, it's pretty mortifying. And I began to rethink really quickly, like, oh goodness. But this was about a patient who was about to get an invasive chest tube that maybe she didn't need. And what he did, I'll never forget. He said, allow me to go to a quiet space. He goes over to a quiet space. And then he starts to ask me questions. He asked me questions like, so when you took the pleural fluid, what did you use to numb the patient? And I was like, I used some lidocaine. He said, how much lidocaine did you use? Did you go on the same track with the lidocaine where you did the sample? And tell me, when you got the sample, what did you do with the sample? Did you put the sample on ice? Did you immediately take it over to the lab? Or did you sit it down and let somebody take it over to the lab? How long did it sit? What happened next? And these were all questions that I hadn't thought of. And he had in his fund of knowledge, because of his experience, some ideas of things that I didn't know. And he said, listen, it is possible that this could be spuriously low for a few reasons. But if you have such a great rapport with this patient, if she's willing to let you repeat the test, go back and this time, don't use as much lidocaine. This time, put the sample on ice. This time, take it straight to the lab and just maybe the pH will be different. And that's what I did. I went down to the lab with this sample and the repeat was 7.34. She didn't get a thoracostomy tube and she went home. And as I think back on it, everything about her presentation fit the illness script of pneumococcal pneumonia, Harold Rigers and shaking chills, sudden ascent in her fever, cough with the rusty sputum, and then antibiotics that quickly, rapidly cause it to resolve. That fit what was going on. And this parapneumonic effusion she had was something small that really didn't require much more than treatment. But really, it just took 3 minutes. 3 minutes for me to spend some time getting to know her by asking her questions outside of the simple things, which are just the things on the H&P. But also 3 minutes is what my attending gave me in his undivided attention that helped us prevent a patient from having something invasive happen to her chest. 3 minutes is also what it took to heat up some cup of noodles, which is pretty much what sustained me through residency. So I began thinking a lot about that attention that my attending gave me, coupled with some of the experiences I had with my senior resident, right? I began to find medical students and I would see them and I'd say, hey, what are you doing? You want to just come with me to admit a patient? Even if they weren't on my team, even if they weren't on internal medicine service, I'd just be like, come with me, come with me. And this is me as a resident. And I kind of got to be known for that, just taking people along with me to go see patients. Why? Because I was just glad to be here, and going to see a patient is always the right idea. Well, as it turns out, that practice would lead to my whole entire career as a clinician educator. I oftentimes would think that clinician educators are people who know everything, right? They're the people who know all the papers and all the cardiology acronyms by heart. Not people that are just going to the bedside and seeing patients with medical students. I guess I didn't ever think of myself that way. But somewhere around my 3rd year of residency, I got a call from my program director's office. And the program director called me to say, we need to talk to you. And I brought into the office, I think I'm in trouble for dictations. And as it turns out, the medical students at Case Western had decided that they would be nominating me as an honorary member of AOA. Now, I was a decent student in medical school, but I certainly wasn't AOA level student in medical school. And the student who nominated me, she said she just would take us with her to see patients. And she taught us that going to be with a patient is always the right idea. She also taught us to sit at the bedside and listen to patients. And then at the end of what she said, she looked at me and she said, I don't know what you plan to do in the future with your career, but whatever it is, I hope it involves you going with medical students and residents to the bedside to see patients. And that day was the day that I decided to pursue a career in academic medicine. Just that simple statement. I wanted to now bring you into the clinic with me for another piece of wisdom that I got from the bedside. This patient, I'll call her Mrs. Evans, and I work in a primary care clinic along with my hospital medicine work. And in the primary care clinic, I have the honor of precepting our residents longitudinally throughout their time in clinic. And so as a result, I'm often seeing the same patients over and over and over again with generation after generation of residents. And this lady, Mrs. Evans, was somebody I had probably seen with 3 different cohorts of residents to come through the program. She was a woman in her 80s, approaching her 90s. She'd lived a really full life and had been married for over 60 years to the same person. And her husband, unfortunately, had passed away a couple years before. But even before her husband passed away, there was always a melancholy about Mrs. Evans that I would always notice. I would ask her questions. I would talk to her about her life. And, she took good care of herself, but there was always like a hint of sadness. And this one particular day, her blood pressure was perfect. Her A1C was pristine. All her labs looked great. And there was really not that much going on other than refill. So I decided on that day I would, sit down and ask Mrs. Evans a few questions. And I began to ask her things like, Miss Evans, how are you doing? Are you okay? And she's like, yeah, I'm fine. And I said, well, I don't know, this might seem weird, but I've known you for a while, and it always kind of sometimes seems like, I don't know, sometimes like maybe you seem a little sad. Like I had screened her for depression multiple times. She wasn't depressed, but there was just this melancholy and I wanted to know more. And Mrs. Evans, looked at me and smiled and she said, don't start asking me those questions again. I'm not depressed. And I said, oh, no, that's not what I'm getting at. I just feel like there is something that is heavy on your soul that I want to know more about. And on this particular day, Mrs. Evans decided that she would tell me. So I'll share this picture here. This is one of my friends who was living in Paris at the time. And this is her in her apartment in Paris. And I share this picture with you because right around the time that I had this encounter with Mrs. Evans, this friend had asked me if I would come to Paris and run the Paris half marathon with her. And, I'm a medical doctor. I'm a mom. I'm a wife. I got a lot of stuff going on, right? And, I signed up for the race, but never had any intention of actually going. But that day that I was talking to Mrs. Evans made me begin to think differently about that. So Mrs. Evans sits down, looks at me, and she says, how old are you? And I tell her my age. She said, do you have children? I said, yeah. She said, what kinds of things do you do just for you? Just because it's what you want to do and nobody else. Something that actually even inconveniences other people. What do you do just for you? And I began to think about, what do I do for me? Like most vacations I take involve my family. Most places I go involve something that is out of convenience to something else that I was doing. It was really unusual for me to do something just because I wanted to do it, just because it was for me. And she said, one of the things, my biggest regrets I have in my life is that I just feel like, look like I didn't ever do stuff. Look like, I never did nothing just because I wanted to do it. I never went nowhere just because it was where I wanted to go. And she grabs me by my forearm and she says, Dr. Manning, I want you to do stuff. And I did the thing we all do. I began to talk to her about like, oh, but you go to the senior center and you do your water aerobics. She's like, that's not what I'm talking about. I'm talking about just going places and doing things just because it's what I want to do, and doing it while I'm young enough to have people hold the door for me, not because they respect their elders, but because they think they got a chance to court me. And I kept thinking about that friend inviting me to come to Paris. And I couldn't stop hearing her saying, do stuff. Her eyes were glistening with tears. And she just said, you know, it's so easy when you work in a place of service or when you're somebody's parent or partner to not do nothing for you. I want you to do stuff. And that day, I went home and I said something to my husband about it. And he said, yeah, you should, which reminded me of the fact that she said, the reason I didn't do stuff wasn't because of anybody else. It was because of me. I never permitted myself to. And I bought a ticket to go to Paris. Even though I'm a mom, even though I'm a Grady doctor, I finally remembered what she said, got somebody to cover my schedule, and I went and ran 13.1 miles through Paris, crying the whole way, y'all, because y'all know I be crying, and thinking about how cool it was that I was just doing something that I wanted to do, a non-repeatable life event that actually inconvenienced to my family. But it was really out of something that she taught me. And as I walked through Paris, I remember somebody holding the door for me. And they didn't hold the door for me because they respected me as an elder. It was because they maybe thought they had a chance to court me, which they couldn't because I'm married. She told me, see about your family, see about your patients, but please see about you and do stuff. I don't know who needs to hear this, who's listening to this grand rounds right now, but maybe that's a message for you too. So as I mentioned, I'm a mother, you all, and I'm a full-time clinician educator. And on this day, this picture was posted to the Facebook group of my son's class. And I had one job as his mama that day for the field trip to the zoo. And as you can see, that one job was for him to wear a red t-shirt along with the rest of the members of his class. And when I got this picture, I immediately broke down crying at what a failure of a parent I was. And that day, I did the thing I always do when I'm feeling bad. I go and sit with a patient. I was on the hospital service. I went and sat down with one of the Grady elders, and I showed him this picture. And I said, what a terrible mom I am. Look at my baby. And he said, look at that boy. Look at him. He's not sad. It looks like, he feels like he's an individual. And I stared and stared at that picture. I thought, is he like, green shirt? Yeah. Or was he sad or feeling othered, right? And I began thinking about the fact that sometimes in our work, it's really, really hard to feel like you're getting it all right. The days that I felt like a good mom, I felt like I wasn't a great attending or doctor. The days that I feel like I'm crushing it as a clinician educator, I feel like I'm dropping the ball as a parent. And that's when sitting at the bedside with a patient who was older than me, whose kids were adults and who had adult grandkids, was where I found some solace. And this was a lesson about the power of presence, about what happens when we physically show up to do things. And my patient told me that day, you know what, Dr. Manning, just show up show up best you can with a full heart and be all in when you get there. Sometimes, you're going to be coming in on two wheels. Sometimes, you might be flying on one wing, but just show up best you can with a full heart and be all in when you get there. Y'all, now more than ever, as a person working in a leadership role at a large institution who works in a space where I care about inclusive environments, especially in these times, that advice is really resonating. Just show up best you can with a full heart and be all in when you get there. And so I took that lesson with me, tucked it into my heart, and was caring for a patient that I'll call Mrs. Dean. And Mrs. Dean was a woman who had been admitted to my team with advanced ovarian cancer, intractable pain, and severe thrombotic disease in her legs that was causing her severe pain. She really did not have any chance for meaningful recovery, short of something miraculous. And we were really supporting her through palliative measures and just kind of helping navigate all of her symptoms at that time. And as I sat with her and talked to her on this particular day, I asked her, what does she need from me? And she said, I need you to help my daughter to let me go when the time is right. Right now, I really feel tired and my daughter is not ready to let me go. And so at that time, she was a full code. Her daughter was often at the bedside and was her only child and wasn't really ready to let her go. And she said, Doc, sometimes all somebody needs you to do is to help them to be brave. So I need you to help my daughter to be brave. And I'm getting really, really tired. And I said, well, how will I know when the time comes? And she said, you just pay attention, you'll know. And I began to kind of think about what she shared with me that day. I thought about all the people that I took care of and what it means to help somebody be brave. But also, I began to think about her saying something else, which was, remember, what you see is your sick patient, but all she see is her mama. Sometimes all somebody needs you to do is to help them to be brave. And I thought about seeing her as somebody's mama and thought about my late father and how most of the time when I saw my father, even though he was growing older and he was getting sick, I mostly saw the person who raised me. And over time, I learned from Mrs. Dean that, this is something that I call love's myopic view, this space where over time, if you're lucky enough, if you sit with a patient long enough, you begin to see who they are outside of the hospital, not just who they are, not just your sick patient, but a glimpse of somebody's mama, a glimpse of somebody's uncle, auntie, partner, sister, friend. And that really comes from time over time and going to the bedside and being with patients. And that love's myopic view is what allowed me to see what was making it so hard for her daughter. But I took the charge that she gave me and came into work a few days later. And on that particular day, it was a Saturday morning, one of these days where I felt like I was doing a poor job as a mom and as a doctor at the same time. And as I come into the lights are low, her daughter's at the bedside. Nurses are walking all around the room and they're saying, her blood pressures are soft, her hands are cold, she's not talking today, she's becoming a little bit altered. What do we do? Should we call a rapid response? What should we do? And her daughter gets up and comes to me and goes, my mom's not doing well. What do we do? What are you going to do? Are you going to put her in the ICU? What should we do? And I walk over to Mrs. Dean and I kneel over and look at her in the face and she looks right up at me. And it's very clear to me that she's lucid and she's tracking what's going on. And I reach down and touch her hand and it's cold, ice cold. And I said, what do you want me to do? And she's staring at me and she's blinking. And I said, do you want me to do what you told me to do? And she just kind of gave me a nod. So I looked at her daughter and I said, your mom told me to help you to let her go when the time comes. She is tired. She believes that you will be okay and that she has equipped you with everything that you need. And now I need you to call anybody in your family who is within 2 hours of this hospital and get them to tell them to get here. Tell them to get here and come see her. And to please, let's stop doing all of this stuff because she's tired. And she looked at her mom and she's like, is this what you want? And her mom didn't really respond, but I said, this is what she told me. And in that moment, her daughter honored her mother's request. We called everybody that was within 2 hours. And this is an actual picture of the family. That's my hand at the bottom with all the people who came in to be with her in that final period. And she was at peace. And when she was at peace, once I left the hospital, a couple hours later, I was called and told that she had expired. My intern called me. I was now at the park with my kids because she needed me to help her to be brave as she went to pronounce the patient. And it went okay. because sometimes all somebody needs you to do is to help them to be brave. And helping people to be brave can go full circle. In 2022, I was on the hospital service, and unfortunately, I got a call that my father had a stroke. I'm from California. My father was out in California. I live in Georgia. And it wasn't a severe stroke, and there wasn't anything that I could really do. And my entire family was just trying to figure out how to navigate it. But had made up my mind that I would, finish my time on the hospital service and then fly out to California. So each day I was a shell of myself. I was rounding and I was trying to get things done, and I was tearful, and I would come in the room. And finally, one of the interns on like the 10th day of this walks up to me and says, "You need to call somebody to come in and cover this service, Dr. Manning, and you need to go home." And I said, "It's nothing for me to do at home." She said, "Do what you would have us to do." And that was what made me leave. Whenever I think about what I did, I went home. I wrung my hands at the bedside with my sister and helped my family to navigate next steps for my dad. But I always remember this intern who had the courage to come up to me to help me to be brave. See, what Miss Dean had taught me about helping somebody to be brave and modeling that to interns, some of the lessons that you are giving your own learners can come right back to you. And it proved to be one of the most valuable things that helped me to not have so much regret when my father passed on. Because sometimes all somebody needs you to do is to help them to be brave. This is Mrs. Dean when I went to her homegoing celebration. And this is what people see through Love's Myopic View. I was grateful that I got an opportunity to see this version of her, which fortunately I had seen just from sitting with her at the bedside. So you probably wonder what happened with Mr. Farrell. Well, it turns out Mr. Farrell got out of the ICU. And when he got out of the ICU, it was very clear. He was clear on a couple of things. He said, "I never, ever want to be intubated again. I never want to be in the ICU again. And I never, ever want to be coded again," because he remembered some pieces of it. And the problem, though, is that Mr. Farrell's non-healing ulcer on his foot had caused him to become septic. And this thing, he had such bad peripheral arterial disease that he needed surgery for it, but he never wanted to be intubated again. This was not compatible with life. So I tell my attending, like, "Look, I know he's now DNR, DNI, but you got to go talk to like anesthesia, and you got to go talk to the surgeons, and you got to go talk to him and get him to reverse that so that we can do surgery on him and fix his leg so that then we can get him better. Because if we don't do anything, like, he's going to die." And I was just trying to like do all the things as an intern. And my attending looks at me and says, "Let's go and talk to him and find out what's important to him." So we go to the bedside to talk to Mr. Farrell. And Mr. Farrell, it becomes very clear to us that Mr. Farrell was tired. He did not want anything heroic. And the biggest concern he continued to have was really about his dog. He just continued to talk about his dog, but he didn't ever want anything else invasive or heroic done to him again. So we get out in the hallway, and my attending looks at me and he says, "I need you to go and call Mr. Farrell's family and everybody within 2 hours of this hospital. Tell them to get here, because what's going on with Mr. Farrell right now is not compatible with life. So please get his family to come here so we can start making a plan." And I'm thinking, what are you talking about? He's not sick. His blood pressure is fine. He's not even hypothermic. Like, he's fine. I said, "Just call everybody." And that's where I learned that lesson. So we called all the family in, and person after person came in, one after the next, after the next. And then late in the afternoon, after all the family had come in and laughed and talked with him, a big commotion happens at the end of the hallway, and we all come out in the hallway, and I see my attending physician at 4 o'clock in the afternoon walking up the hallway. And there's this skittering on the floor that I hear. And y'all, this is in 1996. And in he comes with this Jack Russell Terrier. My attending figured out how to get the dog into the hospital. That dog jumped on Mr. Farrell's chest. He nuzzled his face into the dog. His grandson was at the bedside. He said, "I'll take care of him, Paul. I got him." And when all of that was over, we step in the hallway and my attending says, "Mr. Farrell is at peace. Don't be surprised if when you come back in the morning, he's gone." I thought that was a little bit over exaggerated, but sure enough, I came in the next day and Mr. Farrell's bed was empty. I came to the nurse at the bedside and I asked, what happened? She said, "He just passed away peacefully in his sleep." And it was a death with dignity. And ideally would have been best to not happen in the hospital. We've come a long way since 1996. But what I did learn about was the importance of what I can do, even when it seems like there's so much that we can't do. So my take-home messages for you are simple. There's always an occasion for humanism. No matter how much despair you feel like we're in right now, or how much feels like it's out of your control, there is an occasion. Pay attention. Try to put the pieces together. Some things in medicine don't make sense, but most things do. And 3 minutes is a little, but it can really mean a lot. It may even stop somebody from something really invasive happening to them. Soak up wisdom at the bedside. I know we have work to do on the electronic medical records. I know we want to run the lists in rooms far away from our patients, but the action is at the bedside, and so is the learning. And the only teachers are not the people who are decorated with professorships. It's the people that we care for. Be brave, then help somebody else be brave. And then do for yourself what you'd have others do. Do what you ask your learners to do. And then if you can do something like get a Jack Russell Terrier into the hospital in 1996, use your powers for good. You have more than you realize. And especially remember love's myopic view. Stay with your patients long enough to be able to see a glimpse of what the family is seeing, so that you will fight for them like the family wants you to. And remember that sometimes you are going to win, like my son in that same green shirt when he was dusting these kids in this track meet. Go, son. And sometimes you're going to lose, like my other son when he decided to run cross country. There were approximately 500 people ahead of him in his race, but he stayed slow and steady until he finished. But just show up with the best heart, with the best you can, with a full heart, and be all in when you get there. Whether it is patient care, whether it is in times where what's happening in your world makes you feel like there is nothing you can do, you can still show up best you can with a full heart and be all in when you get there. And always do stuff. Not just stuff that somebody's asking you to do, not just stuff because it's convenient, but sometimes you need to do stuff to fill your own cup just because it's what you want to do. This is a picture from my homecoming at Tuskegee University this past year with my fellow Miss Tuskegee Universities at my HBCU alma mater. And it was really inconvenient for me to go to this. And it is really inconvenient for me to go every year. But it's on my list of the stuff that I do to fill my own cup. And I'll close with some more gratitude for courageous resident role models and attending physicians who take calls at 3 a.m. and courageous learners who remind us of our own lessons. For family who will always see me as mama and not a patient. And for doctors, people, and healthcare team members and students who will sit at the bedside with us until they see a piece of that part of me too. But especially for our patients, our most esteemed teachers, the reason why we do what we do, our true north, and for every single thing happening in this world, reminding us that you are just one doctor, one caregiver with one patient at the bedside, caring about one life, and that is still enough to bring us here to keep doing this work. And last, never underestimate the power of humanism and presence. Turns out in January of 2024, I went to give a talk somewhere in a community event. And at that community event, I was sitting next to a woman who looked a little bit familiar to me, but I didn't know her. And we keep talking. And then after a while, she looks at me and she goes, I feel like I know you. Did you train in Cleveland at Metro Health? And I said, I did. She said, oh, I was your medical student. She was the medical student who years ago looked at me and said, I don't know what you're going to do in your future, but whatever it is, I hope it involves medical students and going to the bedside to see patients with them. And she said, seeing you every day with those patients, it changed what I did. And I want you to know, I became a chief resident because of you two. I had looked for her for over 20 years and serendipitously sat next to her at this fancy event where we wore fascinators and cute dresses. You all, thank you so much. I thought I was going to get all the way through without crying, but I at least gave you a warning that I cry. So thank you so much. And that's all I got.
Dr. Manning, thank you so much for being here to share your wisdom and this dose of humanism at a time when I think we all really need it. I see a lot of hearts coming through the chat. That's wonderful.
I didn't know we could do those. I was like, oh,
Yeah.
be so happy.
Try and recreate some of the love here. For those of you still with us, if you want to add any questions to the chat, I would like to open with one now, which is that one of the central tensions I hear come through in your talk is the competing interests we all face in life. Time with our patients, our families, and then time for ourselves. Crucially, all of these do take time, and anytime we give to one, it risks taking from another. And I wonder how you've learned to prioritize your time, and particularly what advice you would give to people who maybe don't feel they have that agency. I'm thinking particularly of those in training, medical students or residents who think that, or maybe don't have the agency over their time that all of us feel like we do later in life.
I love that question. Because of my first thought, one of the things I've learned is that people don't want as much of your time as you think they do. So that's one thing. So I started this practice where, and David probably even remembers this when with students and others, if somebody stops me, I give them 20 to 30 seconds of my undivided attention. That's actually not a lot of time, but you would be surprised at how infrequently people give you their full undivided attention. And when I began that practice, it started to help me to improve things as a mom, but also as a clinician educator and as a leader. And then also learning to prioritize. I ask myself, what is it that only I can do? And what is it that I'm doing that I really shouldn't be the one doing it? Because, sometimes, I'm a doctor. I like to control things. And I've learned to, when I'm on service, I let my resident be the resident. I'll let the intern be the intern. And I'm not duplicating things that other people do. It then frees up space for me to have a little bit more for myself. When I'm on the hospital service and I work 14 days straight, I tell my team their off days are diastole, but because I have to work every day, my time away from the hospital is my diastelito, my little diastoles. And I'm intentional about what I do with that time. I think about what fills my cup. I'm not going to just do laundry and just cook. So maybe something will have to kind of sit to the side for a moment for me to at least give myself some time to myself. And again, the time you need is not as much as you think, as long as it's dedicated to you. So sometimes it's just going for a run for 45 minutes by myself at a time that is the time I want to do it. Sometimes it's listening to a podcast. Sometimes it's something else. But really beginning to prioritize what matters to me, and then letting it be a non-negotiable, but working a little bit smarter in the places where I do need to work. And I do think that starts with what's getting your attention. Give people like 20 to 30 seconds of your full attention when they talk to you, and you'll be shocked at how short the meeting is. It's just that we're so distracted that people are often, trying to get our attention. And if we give it when they stop us, we can actually get a lot more done.
Wonderful. Thanks so much again. And as somebody who's benefited from your full attention and mentorship in the past, I'm so grateful that you could be here and share this with everyone today. Thanks for visiting us to the University of Washington. Thanks for sharing this wisdom during grand rounds, and thanks for being who you are. We really appreciate
So
it.
much. And y'all, thank you for the heart emojis. I've never seen this feature on Zoom, and it's like I don't know, you don't know what if this feels like as a speaker to see this, but it's a really fun thing to see. I just would also just quickly like to thank Gitanjali for her warmth and for the kindness. And I'll just leave everybody with just some words of encouragement. Our patients need us, our learners need us. And even if you feel like some of the things that we are doing, that they don't matter, they do matter. And sometimes something as fleeting as somebody saying something to you in passing, like, I don't know what you're going to do with your future, but you should be with medical students. You might say or do something that could completely pivot somebody's entire life. And our influence matters a lot more than we realize. Or you might write a paper that shapes someone's entire career, like Dr. Cohen did for me. So just don't underestimate the power of what you're doing and what you can do.
Thank you so much.
Thank
All
you
right,
so
y'all.
very much. And safe travels back home.
Yes.
Thank you.
Bye.